Hello, my clinical case study by Laura Nickel. This is for class RET 4505 for chest medicine. The date of admission for my patient was 7/20 of 2019. The chief complaint was dyspnea. This is history of his present illness. He is a 68-year-old Hispanic male. He presented himself to the ER. He was transported by EMS with dyspnea and COPD exacerbation. The patient has a history of chronic hypoxia. He requires home oxygen at home. He has COPD and asthma. His past medical history. He has chronic pulmonary obstructive disease, so COPD. He has ETOH abuse, chronic hypoxia with home O2 of 2 liters a minute. He has GE reflux and chronic low extremity edema. His surgical history, he just had a tonsillectomy done. His family history, his mother and father both had coronary artery disease and died in their 80s. The patient has, his social history is the patient is married. He has no children. Patient drinks every day, and he likes to go to happy hour at the clubhouse. He is a current everyday smoker. He has a 40-year pack year history and no history of drug use. His hospital medications are albuterol, 2.5 milligrams. He gets those Q4 for wheezing and shortness of breath. He is on methylprednisone, 125 milliliter IV push one time, and that will help reduce the inflammation. He takes aspirin, 81 milligrams, chewable once daily for anti-inflammatory. He's on gabapentin, 100 milligram capsules. He gets those QID, and that's for his pain medicine. He gets omeprazole for 20 milligrams daily for heartburn. Nitroglycerin tablets he takes sublingual, PRN, to prevent chest pain. Glucose oral, 40% daily. Metoprolol, 100 milligrams orally, that is for hypertension. He takes Solu-Medrol IV for inflammation in the lungs. He also takes Mucinex, 600 milligrams daily for mucus clearance, and he takes a nicotine patch because he's in the hospital. He cannot smoke right now, so he gets that with 21 milligrams. His home medications are Advair Discus. He gets 50 milligrams 3 times a day. That's his COPD medicine. Crestor, 20 milligrams daily. That's his cholesterol medicine. Celefexin, 500 milligrams TID, and that's antibacterial drug. He gets Prilosec, milligrams daily for heartburn, and aspirin, 81 milligrams daily as well. His emergency department physical exam, the patient was alert and orientated. He had medium distress, morbidly obese, and he also had slow mentation. His breath sounds were equal, decreased breath sounds with wheezing heard throughout the lung fields. He had symmetrical chest and wall expansion. He had increased AP diameter. BiPAP we put him on. Ventilation, we started it at 40% FiO2. The IPAP was 12, EPAP of 5. His respirations were 28 breaths per minute. He was breathing a tidal volume of 734, and he was tachypnea. His heart rate was 69 beats per minute, and his blood pressure was 172/97. His oxygen saturation was 92%. His temperature was 36.4 Celsius. He had lower extremity edema. He did have a normal heart rate with a regular rhythm and normal heart sounds. There was an ABG drawn on the patient. He was a respiratory acidosis. His pH was 7.20. His PCO2 was 80. And his oxygen, the PO2 was 166 and the bicarb was 30.9. All his lab values were within normal limits. The ones that were high were the glucose, and then the creatine also was high, but all the other labs were pretty normal. There was a chest x-ray, a single AP portable view of the chest. The findings were that the lungs were expanded. There was mild prominence of bilateral lung markings. He had a suggestion of possible small right-sided pearl infusion. His cardiac shilet and pulmonary vascularity were unmarkable. And the person just suggested that a possible small right pearl infusion. That was basically the finding and the impression on this x-ray. The results of his ECG were relatively normal. He was in normal sinus rhythm. They did say probable left atrial enlargement. That was the only thing that was a little different on his ECG. The physician's plan was to admit him to the PCU because they wanted to continuously monitor him on the BiPAP and see if his CO2 level would go down. They wanted to also wean his FiO2, but to keep saturations above 92%, continue him on IV Solu-Medrol, and to continue the Mucinex. They wanted to get a sputum culture, his Laganol, and then also his RVP. They administered the albuterol 2.5 over every 4 hours for the wheezing, pulmonary toilet, and they also wanted to get a cardiology consult on him to make sure that everything was going okay with his heart. The patient was discharged on 7/25. His discharge plan was to keep the O2 at 2 liters a minute. He needed to get pulmonary and cardiology clearance before he was discharged. They wanted him to continue on all home medications. The patient was educated on smoking cessation. That was very important for him to stop smoking. They wanted him to return for a follow-up visit with the pulmonologist within 2 weeks and return with a follow-up of the cardiologist within 2 weeks as well. They also gave him a referral for pulmonary rehabilitation referral. The pulmonary rehab they suggested would help him manage his COPD. And then 7 good reasons for him to go to pulmonary rehab were for him to start exercising, learning breathing strategies, help him with his fatigue, offer support and friendship. He would get disease education, diet advice, and improve quality of life. My differential diagnosis on the patient was the patient did present with shortness of breath, and he did have a history of COPD and asthma. The patient was a current smoker with a 40-pack year history. So the patient is starting to get heart issues because he is not taking care of himself, and that he could go into coronary artery disease, CHF. He needs to change his lifestyle, and I think pulmonary rehab will go ahead and help him do that. I would suggest that he change his diet and, just start living a healthier lifestyle. That is my patient. Have a good day.